Hey everybody, welcome back. Today we are going to continue with more respiratory infecting bacteria. Moriselli Catarrhalis is a gram-negative diplococcus in the family Neisseria. And more importantly, it's bean-shaped, it's oxidative positive, and it doesn't ferment sugars. It is going to be a human disease or a human pathogen. The reservoir is in the pharyngeal area, and it's going to be transmitted via droplets to children, and elderly patients with underlying conditions are generally the risks. It's the third most common cause of otitis media and sinusitis in children. Second cause, remember, is strep pyogenes. The bronchitis and pneumonia is going to be caused in the elderly, and you want to treat them with amoxicillin plus clavulanate, augmentin, or a second, third generation cephalosporin, which includes trimethoprim or sulfamethoxazole, since most of them are penicillin resistant. Klebsiella pneumoniae is an encapsulated enterobacteria. It's a non-motile gram-negative rod and a facultative anaerobe. So it produces lactose, oxidase negative, indole negative, and it forms gas. It has the urease enzyme, and it grows on most cultures as a mucoid colony. And the reservoir is going to be in the gastrointestinal tract or the upper respiratory tract. Sorry, I see you and I always think urinary. So it's going to be transmitted via aspiration or exogenous infection by contacting fomites. It's one of the top 10 nosocomial, sorry, you can never pronounce things, infections, which means you can get it really commonly in the hospital. Risk factors, for some reason, it's more inclined to infecting males and in patients with COPD, alcohol abuse, and diabetes. So it causes the respiratory tract infection, septicemia, and this time the urinary tract infection. So it's unfortunately 50% the mortality. So pretty bad odds, to be honest. Why is that a 50% mortality? Because it causes necrotic destruction of the alveolar spaces. So it literally punches holes in the lungs. Not only does it punch holes in the lungs, it also produces an endotoxin, which can cause the septic shock. The sputum is characterized by this thick, blood-tinged, jelly-like viscosity, and thickness is going to be due to the capsule. You diagnose it via the gram stain, the McConkey culture, and lactose fermentation. The treatment is really tough because it's fairly antibiotic resistant. So you got to treat it with a third-gen cephalosporin and aminoglycoside. Unfortunately, there is no vaccine. Pseudomonas aeruginosa is a motile gram-negative rod that usually appears in pairs, and it makes a blue or yellow-green pigment on the MHA plate. It's an oxidative positive, non-fermenting, aerobic, and beta hemolytic appearance. It makes a fruity grape-like odor because it makes 2-aminoacetophenone. The reservoir is going to be in warm, still water, so it's in the air conditioners and the soil. The transmission is via the inhalation of the water or touching contaminated surfaces. So it can also cling to the medical devices, and it can aggregate in the eye and cause keratitis. And it's also very, very tough if it gets into the wounds, and it's tough to treat because it causes these deep infections, and very, very bad news for patients with fibrosis because they can enter, make clusters, and form a mucoid biofilm. So it uses pili and LPS and a capsule to adhere, and the endotoxin is an AB exotoxin that inhibits EF2, which is the elongation factor that codes for protein synthesis, so it makes the cell die. The Pseudomonas aeruginosa also makes pyocyanin, which catalyzes the production of the O2 radicals to stimulate IL-8, which attracts the neutrophils and causes inflammation. So pyoverdin is a siderophore, and it binds iron. Phospholipase C is going to digest the lecithin and cause cell lysis, and the elastases is going to, of course, damage elastin. So the capsule, the endotoxin, and the antimicrobial resistance is all going to play huge roles in the virulence. So the diseases can kind of vary. It can be like tracheobronchitis and necrotizing bronchopneumonia, or it can turn into bacteremia and endocarditis. The skin is going to manifest as ecthyma gangrenosum. It can also be external otitis, and the malignant form can occur in the diabetic or elderly patient. The external otitis can move inwards and cause chronic otitis media. Not good in burns either. It's like one of the top opportunistic infections or opportunistic pathogens in burn victims. And it causes folliculitis. And it can also infect the eyes, give you a UTI, and cause osteochondritis of the foot after some kind of penetrating injury. Luckily, it's treatable, but it's a lot of really hardcore drugs, and usually given in combination. So you want to give them as anti-pseudomonal beta-lactam plus aminoglycosides or a fluoroquinolone. It's tough, though, because there's multi-drug resistance. So how do we prevent it? You gotta use very strict antibiotic policies. Make sure your patient finishes all of the regimen. Only prescribe if necessary. You want to call attention to the infection control, sterilization, and chlorination of hot tubs and swimming pools. Burkholderia Sepasea complex is a complex, though it's not just one. It's 17 different species. It's a gram-negative bacilli. It's an aerobic non-fermenter, and it's oxidative positive. This one doesn't make pigments. And the reservoir are going to be your moist environment, transmitted by inhalation or contact with the contaminated surfaces. The risks include patients with COPD, cystic fibrosis, and kind of immunodeficient patients. It can cause either mild bronchitis to necrotizing pneumonia, and UTI is also one of the characteristic symptoms. We diagnose using a culture with polymyxin, and you treat them with trimethoprim or sulfametazole. You want to, just be sterile, maintain hygiene, and chlorinate your pools. Actinobacter Balmani is a gram-negative coccobacillus that is non-motile. It's aerobic and oxidase negative. It's a non-fermenter and very resistant to antibiotics. It's pretty contagious too, and it's one of the top, hospital-acquired infections besides Klebsiella pneumoniae. It's an opportunistic pathogen, and it really targets patients on respiratory ventilation, catheterized patients. So those are going to be your dialysis patients and patients on broad-spectrum antibiotics. So the outer membrane has a protein A for adherence, and the pathogenicity islands are going to code for the toxin along with the antimicrobial resistance. On top of all of that, they also have a biofilm formation. So it causes typical pneumonia and septicemia, UTIs, and infections in the elderly and ICU patients. And it can also cause a soft tissue infection from generally gunshot wounds caused by the Iraq bacillus. You are going to diagnose it on a blood agar or a McConkey agar or TSI agar. And they're going to appear like here. So once again, kind of like a mucoid, pinky colony. It's difficult to treat because some of the strains are resistant to all known antibiotics, so not great. What can we do? Hygiene and environmental cleaning. Unfortunately, there's no vaccine. Legionella Pneumophila is a gram-negative coccobacillus, and they are motile and an obligate aerobe. They're tricky to stain, so you have to use a specific deuterial silver stain to see them. The reservoirs are going to be in your ponds, AC, hot tubs, humidifiers, and the CPAP machines. It's resistant to chlorine and temperature changes, and the transmission is via the inhalation of contaminated aerosol. Luckily enough, it's not person-to-person transmission. So the risk, of course, patients with lung diseases and immunocompromised patients. It's a facultative intracellular pathogen, so it's going to infect the alveolar macrophage monocytes and the alveolar epithelial cells and live inside of them for a while. C3b is going to be deposited on the outer membrane protein, and it facilitates the phagocytosis but no fusion, so there's no killing. Once it's done replicating and making its own enzymes, it's going to lyse and kill the host cell. And those infected host cells, before they lyse, they're going to send out a bunch of cytokines to warn all the other cell and cause a pretty significant inflammatory response. So there's two different types. It can be Legionnaire's disease or Pontiac fever. Pontiac fever isn't too bad. It's about like it's a flu-like symptom, lasts about a week. There is no pneumonia, and it's self-limiting, so nothing is really given. Legionnaire's disease is atypical pneumonia, and it can incubate for 2 to 10 days, and it presents as a severe toxic pneumonia. So rapid onset, and then first it starts with the initial patchy interstitial filtration, and then it's going to develop into consolidation along with the microabscess. So once it involves all of that, there's going to be multi-organ involvement and then hyponatremia. How do we treat? We use DFA staining along with the deuterial stain, or silver, and it has to have BCYE agar as the medium because it needs cysteine and iron to grow. So they're going to appear as these like kind of whitey colony on a black agar. You can also use immunoassay or LPS antigen testing, ELISA testing as well. And the treatments were going to be macrolides and fluoroquinolones. Mycoplasma pneumonia is a common cause of the community-acquired pneumonia. It's the most common cause of atypical pneumonia and pneumonia in young adults, so both. There are no cell walls, it's pleomorphic, and there are sterols in the cell membrane. So since they're sterile into the cell membrane, most cell wall inhibitors like beta-lactams, remember, work on ergosterol, so these are resistant. Humans are the reservoir, spread by droplets. Risk, anybody living close together. Infections are generally in the summer and fall. It has a P1 protein, which binds to the sialic acid on the ciliated respiratory epithelial cell, and that can cause the tissue damage. Hydrogen peroxide is going to cause the superoxide radicals and the cytolytic enzymes to kill the cell to destroy the ciliary action. Unfortunately, it acts as a super antigen and it can cause a cytokine storm. So first, it's generally mild, but if your immune system is down, it can progress to pharyngitis, tracheobronchitis, or walking pneumonia. The complications would be the hemolytic anemia, the neurologic abnormalities, and the Stevens-Johnson syndrome. Stevens-Johnson syndrome is the hypersensitivity reaction, and that affects like the skin. The skin's going to ulcerate. Incubation time is pretty long, it's about 2 to 3 weeks. And when you grow them, you have to grow them on an A8 agar, and it's going to appear as like a fried egg. Or mulberry colonies, either or. It's going to be positive, a cold agglutinin test. It's non-specific though, so you want to use a titer instead. ELISA also works, and you treat using tetracycline, doxycycline, erythromycin, or quinolones. Prevention, since it's pretty resistant to a lot of things like temperature changes, chlorine, stuff like that. Maintain hygiene, and if you catch it, absolute quarantine and isolation. Chlamydophila pneumonia is an obligate intracellular bacteria. It has a cell wall, but lacks the peptoglycan and the muramic acid, so it doesn't stain with gram stain. It has a biphasic growth cycle, where in the first phase they are elementary bodies, which are infectious and metabolically inactive. And then it matures into the reticulate bodies, which are non-infectious and metabolically active. And those appear as the inclusion body in our cells. So first, an elementary body attaches a cell, gets fused in, and reorganizes into the reticulate body. From there, it's going to grow, and there it's going to will undergrow and then like divide into binary fission, and then it buds out, and then the cell lyses. It's also known as the Taiwan acute respiratory agent, and it will infect the respiratory cells along with the macrophages, the endothelial cells of the coronary artery, and the smooth muscle cells. So mostly it's asymptomatic, incubates for a while, about 3 to 4 weeks, and the disease process would be pharyngitis, sinusitis, bronchitis, and atypical pneumonia. Complications would be the exacerbation of asthma, encephalitis, and myocarditis. It's associated with people with atherosclerosis, Alzheimer, and reactive arthritis. It's hard to diagnose because it's not sensitive to any staining, so not really useful in using gram stain. It will grow in a Hep2 cell line, and you can use DFA stain. The best method is serology. So you're going to use MIF or complement fixation tests. The treatments are going to be macrolides, tetracyclines, or fluoroquinolones. Unfortunately, there is no vaccine. Chlamydophila psittaci is pretty rare, actually. It's also known as parrot fever. It's carried by all sorts of birds, but here in the U.S., the turkeys are the main reservoir. It's present in like basically anything made from a bird. Transmission is really inhalation. It's not transmitted from person to person though, so it's really confined to like vets, farmers, pet shop owners, and zookeepers. So after inhalation, it's going to infect the mucosal epithelial cells and the macrophages, and it spreads to the liver and the spleen and cause the focal necrosis, which is not great. Starts with bronchitis, pharyngitis, and sinusitis, so it affects really the lower respiratory tract. And in the severe cases, it causes the hepatosplenomegaly, GI, CNS, and eye infection. So the diagnosis would be either serology using complement fixation or MIF. The treatment would be doxycycline, macrolides, and fluoroquinolone. Prevention is treating your pets, and you give them chlortetracycline. Bacillus anthraxis is going to cause anthrax. It's a large aerobic gram-positive spore-forming bacilli, and it makes like all these chains, as you can see here. And unlike most bacteria with peptidoglycan capsid, this has a polyglutamic acid capsule. The reservoir are in soils and animals, particularly hippos, sheep, and cattle. And the transmission is going to be contact with an infected animal and their products. There is no person-to-person transmission, so that is pretty good. It can enter through injured skin, inhalation, or ingestion. The capsule is going to prevent, of course, the phagocytosis, and the anthrax toxin is AB toxin. So the A part is a protective antigen, it's the binding unit, and it helps mediate entry. And then the edema antigen adenylate cyclase is going to elevate the CAMP and cause edema. The lethal factor is a zinc-dependent protease that inhibits a lot of kinases, and that kills the host cell. It can cause cutaneous anthrax, which is Hyde-Porter's disease, where the wound inoculates like this. Oops, I'm sorry. It causes a pruritic papule or vessel that enlarge and erodes, and then eventually leaves behind a necrotic ulcer with a black eschar. That's what this is called. And with raised edematous edges. The intestinal anthrax is rare. It's pretty fatal though, but it's usually in animals that graze. Inhalation is more common in humans, besides the cutaneous anthrax. It's also known as the wool sorter's disease, and this is the most serious form. It can incubate from 1 week to 2 months, and the alveolar macrophages are going to consume it, and the spore lives inside of it in a dormant phase, and then that spreads to the lymph nodes. And then it can cause the atypical pneumonia symptoms, and that degrades into respiratory distress. So that's going to cause the massive chest edema, the hemorrhagic mediastinal lymphadenitis, and the widened mediastinum. This can also cause the hemorrhagic pleural effusions, bacteremia, and toxemia. So that causes cyanosis along with shock, and then there is death within at least 3 days. It's pretty deadly, and it's really hard to treat. So diagnosis is gram-positive. It's a non-motile rod in a bunch of chains. You can use DFA to detect the capsule, but we use the amphidian methylene blue stain to see the capsule. On the culture, it's like a non-hemolytic, white, gray, rough-looking colonies, and it can look like ground glass or the medusa head. You give Cipro or doxycycline along with 1 or 2 others, and those would include rifampin, Myvanco, penicillin, imipenem, and clarithromycin. There is a vaccine, which is a partially purified protein. You give that in multiple doses. So you give that to patients who have interactions with these animals. You can also give it to animals, and then boosters are also available. That's it for now. Thank you for your attention, and good luck studying.